So as you go through the readings for this module and you think about cancer and oncology and HIV/AIDS, some interventions to consider and some ways of working with these clientele, you want to consider that, cancer is a disease in which abnormal cells divide uncontrollably and they destroy the body tissue. And there's a fair number of us, 39.6 of men and women who will be diagnosed with cancer at some point during their lifetime. And as you can see, there's a whole host of common cancers, but then there are many cancers that we may not be familiar with. And some of these cancers have the potential to be more aggressive and malignant. Therefore, turning the lens to sort of that palliative care, comfort, hospice versus rehabilitation for the client with cancer. So some considerations when you're working with this clientele, that understanding that providing OT intervention can be very complex, especially when you need to understand the disease, the treatments, the medications, how the body's response can be impacted. So some of these body functions that might be impacted could be change in heart rate and rhythm. So we're always monitoring vital signs with these clients. There could be dizziness, again, changes in blood pressure, changes in vision, cognitive status, appetite, or metabolism. Those changes in cognition and vision could be specific to the chemoradiation. It could be specific to it being a brain tumor. The change in appetite or metabolism, again, could be due to medications. It could be due to change in the way things taste. So we really need to consider nutrition and how to keep our clients' nutrition up. So as an intervention, you might be considering getting into the kitchen and cooking something that they really love in a way that tastes meaningful to them, or that actually has some sort of flavor. So when you're considering those vital signs, as we said, you want to make sure that you're doing always monitoring their vital signs, blood pressure, arterial pressure, understanding what that changes in intracranial pressure might be. So if somebody maybe is having hydrocephalus and the intracranial pressure goes up, if their respiratory rate changes, what does that mean? If their heart rate changes, what does that mean? If they're having desatting, deoxygenation, what does all of that mean for the client? How are they going to feel? Is it going to change their endurance? Is it going to affect their ability to be upright for an intervention? Do you need to grade and adapt to in a wheelchair or at bedside level? Because that could even change session to session, depending on, how the client is feeling. You really want to be familiar with what the lab values mean. So if the red blood cell count goes down, that could be a sign of anemia, and does the energy level might be different. The white blood cell count might go up, and that means maybe there's an infection. Understanding the coagulation panels, are they more at risk for a blood clot that could break off and cause a stroke or an MI or a PE? So kind of understanding what those different lab values mean, and just a basic metabolic panel if their blood sugars have been impacted by the chemo or radiation, if their calcium is low based on, if they've had a long-standing history of chemo radiation and now their bone density has been impacted, maybe they're at greater risk of pathological fractures. So just keeping those things in the back of your mind as you're looking through their labs. And what this means for your intervention is that, exercise may vary depending on the type of cancer, the type of treatment that they're receiving, the reaction both metabolically and physically. They might be Any sort of resistive weight exercises might be contraindicated based on the brittleness of their bones. K-tape or E-stim might be contraindicated because of where the malignancy is. So kind of understanding what all of that means. And the other important thing to remember is that cancer is not always malignant. You could have somebody who has a brain tumor, but once it's resected or removed, they don't need any further treatment. So just because somebody has cancer, it doesn't mean that they're going to be dying. So we should, just be familiar with what radiology and imaging looks like. So we should always be in contact with the doctor if they come in with CT scans or MRIs or X-rays, or if they have follow-ups. What do the scans actually mean? Does it show that the tumors are growing or receding, or does it show that there's a fracture, or where in the body the metastases are? If somebody has lung cancer and the cancer has spread to different parts of the body, what does that mean? What does that look like on that imaging? Big picture, before you do any evaluation and treatment, before attempting resistive exercise, manual muscle testing, weight bearing, any sort of mobilization, you always want to verify vitals, blood counts, images, to make sure that you are not potentially doing something harmful to your client. So when you're working with this clientele, some secondary conditions that you might be managing that could impact occupational performance could be cancer-related fatigue. They just might overall be exhausted physically, emotionally, cognitively, from the perspective of where the cancer is, or from the perspective of the treatment, or how the cancer is impacting them from that mental health state. And then, we know that rest and sleep is an ADL, and the rest and sleep can worsen with these symptoms. Secondary condition could be cancer-related cognitive dysfunction. There could be those impairments with memory and executive functioning and attention span, and this could be temporary because it's related to treatment, fatigue, or a mental health status, or it could be permanent for, let's say, brain tumor or metastases to the brain. So you could also have somebody with chemotherapy-induced peripheral neuropathy. So we understand that peripheral neuropathy is the numbness in the hands or the fingers. So this could be somebody who's experienced, who's been receiving some sort of chemotherapy agent, and it's caused dysfunction or damage to the peripheral nerve. And this could repair, or it could take months or years to repair, or the recovery may not happen. So as you look through these, you'll see that we've also highlighted some treatments for this client. Some other considerations are cancer-related pain, understanding what the triggers are. Pain is very, very much subjective to the client. So really understanding what those pain levels mean, how do you manage them, how do you grade activities, how do you incorporate visualizations or mental strategies to move through those pain cycles. Deconditioning is a huge consideration where they just lose functional capacity because of lack of activity for a whole host of reasons. It could be being in the hospital after having the tumor resection. It could be prolonged bed rest because of fatigue. So really understanding where the deconditioning is, why they are deconditioned, and then really encourage them to get mobilized. Because with most of our clients, the more they lay in bed, the poorer their results overall. And then we want to consider the cardiovascular and pulmonary systems, understanding how endurance has been impacted, how inactivity can cause changes in the muscles and the cardiac function. And if we throw a large volume of exercises at that client who is deconditioned, has their cardiovascular pulmonary system has been compromised, how that increases their risk of further complications. So there are some psychosocial issues that we also need to consider. Body image, if somebody's had a surgery where they have had some sort of resection. Breast cancer survivors where they've had to have a mastectomy, or somebody who's had their brain surgery where now they've had their skull has been a craniectomy, or somebody who had a sarcoma and they had an amputation. So we really need to consider that component as well, and how, on top of the cancer, how it can increase the risk of depression and anxiety, and how body image and self-efficacy can be impacted. And thinking about the stress management and coping strategies, relaxation techniques, education, how sex and intimacy is impacted, and what interventions you might be able to use to support those components, how interventions to support body image, and so on. I'm not going to get too much into this slide since you've all had your lymphedema field work, but this lymphedema is a huge component of cancer, is a cancer-related impact of cancer. So palliative care and hospice. Palliative care specifically can be initiated at any point during the patient's illness. Curative interventions may be used. This is an opportunity to keep somebody comfortable. Hospice occurs when there are no curative therapies and the end of life is more imminent. So our role with this patient oftentimes can be inpatient or at home. It's very much client-centered, occupation-based, and it's really helping the client and the family identify goals, perform occupation roles. You're also looking at home modifications, first floor setup, just making it easy or the client's environment more accessible, DME recommendations, family training with ADLs for mobility and transfers. So you're really preparing the family and the client for that gradual or maybe sudden decline in function, so that everybody is safe and everybody's needs are met. So let me just go back. So let's switch gears real quick from cancer and palliative care, hospice care, to HIV infection and AIDS. So HIV is the virus that is caused by AIDS. They are retroviruses that replicate by viral genetic material that is encoded in the RNA. HIV is transmitted through exchange of bodily fluids from persons with HIV, so with all patients, but certainly using your standard precautions, gloves when handling any sort of bodily fluid with clients with HIV/AIDS. The risk for infection in healthcare is quite low, but it is imperative that we do wear that PPE when we anticipate coming in contact with bodily fluids, and of course any disposal of needles or other infectious sharp objects. And I think we've heard many of the tales of somebody putting their hands in the bed ungloved and getting pricked by a needle. But these potential things are real, so making sure that you're using proper and safe practices when working with clients with any sort of infectious disease. So there is no cure for HIV/AIDS. There is the antivirals, the antiviral therapies that have been shown to improve immune function, but still there is no cure. But you will come across, many people in your career with a history of HIV/AIDS who are on medications, but who are also not on medications for a whole host of reasons. So neurological impairments are very common with the neurological sequela of HIV/AIDS, with plaque development within the brain related to the HIV/AIDS. And as you know, neurological impairments can be very impactful upon ADLs and IADLs. You might see peripheral neuropathy and neurocog impairments. The antivirals have certainly decreased the severity of the impairments, but they are still there. So whenever you're working with somebody who has HIV/AIDS, regardless of where they are in the process, we really want to consider those neurological components. So I'm not going to get too much into neuropathy. This is something that we should be very familiar with, but can be a really impactful dysfunction on occupational performance. So always assessing cognition, always assessing pain and neuropathy. And then as the severity of the HIV/AIDS, you might see these neurocog disorder of dementia. And this is very common because with the infection, it's possible that the blood-brain barrier might prevent the antiviral from passing through to the CNS, which might cause the AIDS dementia complex. There could be that component of plaque development within the brain. The research is not entirely clear as to the etiology of the dementia, but you might see end stage, later stage signs of the AIDS dementia complex. And these symptoms will look quite similar just based on what stage of these deficits we're seeing them in. So you might see impairments in executive functioning, balance, again, sensory changes, behavior changes. You just think cognitive impairment and you can or neurological sequela, and you can come up with a whole host of signs and symptoms that you might see. So some of the client factors that might be impacted: fatigue, impairments of the central nervous system, impairments of the peripheral nervous system, vision. Pretty much every area of occupational performance will be impacted by these changes in client factors. So prevention. As the OT, we want to think primary prevention, development and implementation of health education and risk reduction. Secondary prevention, providing our services for people who are already infected and sort of promoting health and well-being, healthy lifestyles, looking at preventing future infections or health and wellness imbalances, establishing healthy roles, routines, occupations sooner than later. And then when that tertiary prevention provided when clients suffer from a disability that is secondary to the disease. So emphasis on rehab and engaging with occupation through modification. So advocacy, education, maintenance and restoration, modifications, adaptations. So when you look through your OTPF interventions, it's pretty much all of the areas of intervention that we will address. And if you have any questions, don't hesitate to reach out.